Welcome back to the Critical Care Shock Lecture Series. In this session, we'll be discussing volume administration during shock. More specifically, we're going to break this topic into three parts: fluid resuscitation, fluid responsiveness, and fluid tolerance. In this recording, we're going to target fluid resuscitation part 1. Before moving forward, disclosures and disclaimers. I have no relationship with industry. I have no financial conflicts. Let's look at our objectives and goals. We're going to first start with the introduction, then we're going to discuss what tools are available to us in regards to fluid resuscitation. And lastly, we'll discuss fluid resuscitation and de-resuscitation strategies. The decision to give critically ill patients fluid is a very frequent and sometimes very challenging task that pretty much all critical care providers face multiple times throughout the shifts. These are challenging decisions partially because the stakes are so high. In the setting of hypovolemia, under-resuscitation leads to inadequately perfused tissue. This leads to ischemic injury, and ischemic injury leads to organ dysfunction, and this leads to increased risk of morbidity or mortality. But on the other side of the conundrum, over-volume resuscitated patients also face increased complications, increased ICU length of stay, increased morbidity, and increased mortality. And even in a perfect situation, a fluid resuscitated patient suffers from some degree of fluid and salt excess. So again, this makes for a very tough decision. We're always trying to balance restoring cellular perfusion while preventing volume overload. This is easier said than done. We're always striving to prevent that under or over resuscitated situation and find that Goldilocks just right target. Let's move on to talk about IV fluids. In a general hospitalized patient, there's 4 indications for IV fluids: resuscitation, maintenance, replacement, and total parenteral nutrition. We're here to talk about resuscitation, but let's just take a minute to talk about the other indications. First, we have maintenance. It's my personal opinion that in the absence of a metabolic syndrome or a salt wasting syndrome or a water wasting syndrome, maintenance IV fluids don't belong in the ICU, at least an ICU that's staffed 24/7 by providers or docs. Daily water requirements should be replaced enterally whenever possible. The next indication would be replacement, and most commonly, think about IV replacement of electrolytes. Now again, if the gut works, use it. We should be replacing enterally, but certainly there's many situations that we would revert to an IV replacement of electrolytes in the ICU. And lastly is nutrition. You'll see that I changed this to total parenteral nutrition. And the reason I did this was to combat a horribly dogmatic, antiquated teaching. IV fluids are not nutrition. They are not calorie repletion. With that said, unfortunately, there's plenty of folks out there in the world that think when we give dextrose to a patient, we're providing them nutrition. I would like those same people to understand that there's less than 200 calories in a bag of dextrose 5%. So to maintain accuracy, I've changed this to total parenteral nutrition. Now let's just talk about the shock patient. What is the only indication, the only goal for giving fluid to a shock patient? And the answer to that, as most of us know, is to increase stroke volume. That's the only reason to give fluid to a shock patient, is to increase stroke volume. In fact, if this doesn't happen, fluid serves no purpose and is likely to be harmful to your patient. Recalling from previous lectures, in a hypovolemic patient, stroke volume is increased by the volume increase in the mean systemic filling pressure. This increases the venous return, increases the RV preload, increases the right ventricular end diastolic pressure, thus increasing the left ventricular end diastolic pressure, and that increases our stroke volume. We know that this increases cardiac output due to increase in stroke volume and a presumed constant heart rate. This increases oxygen delivery, thus restoring perfusion. So now with us all on the same page, understanding the only reason that we give fluid to a shock patient is to improve stroke volume, I have a question for you. During a fluid responsive shock state, do you want to increase stroke volume over 30 minutes, i.e. a bolus? Or do you want to increase the stroke volume over 12 to 24 hours, i.e. an infusion? This is obviously a loaded, sarcastic question, but it's one that really needs to be voiced aloud. The answer is obviously option 1. It's an IV bolus. The physiological and logistical aspects of answer 2 are just asinine. Fluid should be given as an IV bolus when caring for a shock patient. Still don't believe me? Still insist on ordering IV fluids? Well, take a look at this. So let's have a brief discussion about hidden fluids. But before moving forward, everything is hidden if we don't account for it. Hourly I's and O's and daily weights are a non-negotiable standard of care when dealing with the shock patient. With that said, there's 2 genres of fluid your patients are getting on a daily basis in the ICU. The first would be discretionary. And the way I think about discretionary, these are the things I know about. This is what I order. This is what I'm aware of. And examples of this would be my IV fluid boluses. If you're still ordering maintenance IV fluid, that would be there as well. Nutritional and blood product. I have stars on nutritional and blood products because I still foresee that there may be some hidden components to this. An example in nutritional would be just a little extra free water boluses in that feeding tube to get get maybe a medication through the feeding tube itself. And then in blood products, it's been my observation that it's very easy to follow a transfusion with a mini bolus chaser, if you know what I mean. The next genre of fluids would be hidden. And obviously this is what I'm not aware of. This is not what I ordered, or at least what I directly ordered. And examples would be IV medications, IV infusions, and electrolyte replacements. Examples of IV medications would be IV antibiotics, and then IV infusions would be your KVOs. Honestly, these days, I think a lot of facilities have been paying a lot of attention to KVO rates, so things are better. But I remember back in the day, you could see a KVO of 5, a KVO of 10, of 15, even upwards of 50 mLs per hour. So this was a significant intake contributor. So I looked to literature to help me answer just how much hidden fluids do we think that we have in the ICU, and I was actually startled by the result. They showed a mean hidden fluid amount of nearly a liter and to the upwards of 1.5 liters per day. So again, that's 1.5 liters a day that you weren't necessarily aware that your patients were going to get per your orders. The two studies cited on this slide really helped illuminate this concept for me. When we looked at discretionary fluids, the fluids that I knew the patient was going to get, it broke it down quite reasonably. 77% was parenteral IV fluids, 21% was enteral, and 2% was blood. This is all very reasonable. Now, each study gave a breakdown of their hidden fluids. Here you see the first paper. You see approximately 38% of hidden IV fluids was your IV antibiotics. 16% was your pain, agitation, delirium medications. 11% was vasoactive. 16% was electrolyte replacement. And another 13% was IV flushes. The other paper broke it down just a little bit different, and we saw up to 49% of the hidden IV fluid being your IV antibiotics, 21% being your electrolyte replacement, 16% being your pain, agitation, and delirium medications, and up to 14% being your vasoactives. This concept is another reason why I don't routinely prescribe IV fluids. The patient's already getting excess volume. They're actually already getting the near equivalent volume of maintenance IV fluids over 24 hours. How much more maintenance IV fluids do you want them to have? And don't you think that additional maintenance IV fluids in this situation put your patients at risk? Let's think twice before routinely prescribing maintenance IV fluids. Let's lighten things up a bit here and start talking about the fun stuff, the tools of our trade when it comes to fluid resuscitation. So what are the tools of our trade? We have blood products, crystalloids, starches, and albumin. Let's take some time to individually explore some of these treatment options. First, let's start with blood products. Fortunately, this isn't a lecture on blood transfusion or blood administration, so we're going to keep this simple and short. Lose blood, need blood, we give blood to you. Giving crystalloids to replace blood is a very unwise decision. In fact, crystalloids should only be a temporary judicious tool that we use while we wait for the blood coming up from blood bank, because doing otherwise we know causes hemodilution. Hemodilution causes decreased oxygen delivery capabilities due to the anemia, causes dilutional coagulopathy, and it also increases mortality. This is probably best studied in the trauma patient, where the administration of greater than 1.5 liters of crystalloid is associated with increased mortality. Moving forward to starches or synthetic colloids, we'll make this discussion short and simple as well. Don't use them. There's a plethora of literature demonstrating increased rates of AKI, increased need for renal replacement therapy, a trend towards increased bleeding, an increase in need for blood transfusion, and in one major study there was actually an increase in mortality. Long story short, starches are not to be used. Now let's slow down and spend a bit of time on albumin administration. It's important to point out that our conversations pertaining to albumin are really in regards to treating shock and hypovolemia. So albumin discussions regarding HRS or large volume paracentesis or nephrotic syndrome call for additional discussions outside the construct of this lecture. As we know, albumin is a natural colloid. So the general historic teaching of albumin really revolves around colloid osmotic pressure. With that, there's opposing forces of the colloid osmotic pressure and the hydrostatic pressure. With that, every good critical care provider understands that the normal plasma colloid osmotic pressure is between 25 and 27, where iso-onconic albumin, which would be 5% albumin in the US, has a colloid osmotic pressure of 20. Hyperoncodic albumin, or 25% albumin, carries a colloid osmotic pressure somewhere between 70 and 100. The thought is that albumin not only stays in the vascular space better, but it causes venous reabsorption of the fluid. This reabsorption pulls the fluid from the interstitial space back into intervascular space, and this is due to the oncodic gradient. And between the thought of the increased intervascular space retention and the venous reabsorption, the 3-to-1 rule was created. And this rule really stated that 1 liter of iso-oncodic albumin is equal to 3 liters of crystalloid when it comes to resuscitation. So overall, we were trained to like albumin for its presumed volume-sparing effect. We'll discuss the accuracies of such teaching shortly, but first, let's see if albumin is safe. Due to the conflicting outcomes of meta-analyses in 1998 and 2001, the well-designed SAFE study was published. Briefly, the paper compared the use of 4% albumin versus saline in the ICU, and the primary outcome was the all-cause mortality at 28 days. And as you can see, there was no difference in death, rate of organ failure, ICU length of stay, hospital length of stay, vent time, or rates of need for renal replacement therapy. However, in a predefined subgroup, trauma patients, there was actually an increase in the relative risk of mortality. And the authors conclude this to be secondary to the rates of traumatic brain injury patients that were enrolled in their trial. 7 years later, there's a manipulated post hoc analysis of the identical data, and with that, there was a trend towards reduced risk of death in severe sepsis patients. My 2 cents on this paper was redone 7 years later with comparative data. Seems somewhat suspect to me. The repeat post hoc analysis looked at 7-day mortality rather than the 28-day mortality in the original paper. And then lastly, it's an unplanned post hoc analysis. So these results might just be a coincidence. It's very difficult to interpret, and the results can be misleading. In the initial study, it was interesting. This 3-to-1 rule that we were all taught was not accurate. It was more like 1.4 to 1. That is 1.4 parts crystalloid to 1 part colloid. More on this in just a minute. Now knowing this information, let's move on to the 2021 Surviving Sepsis recommendations concerning albumin. Recommendation 34, for adults with sepsis and septic shock, we suggest using albumin in patients who received large volumes of crystalloids. Let's point out this is a weak recommendation. Next, let's point out that there's no defined cutoff for quote-unquote large volumes of crystalloids. And lastly, let's look at the rationale. The suggestion to consider albumin in patients who received large volumes of crystalloids is informed by evidence showing higher blood pressures at early and later time points, higher static filling pressures, and lower net fluid balance with albumin. Let's dig into this rationale just a bit deeper here. So first we have the meta-analysis from Martin and Bassick. And they were asking a clinical question just a little bit different. They were asking, are crystalloids sufficient for volume replacement during ICU stay? And they concluded that crystalloids were less efficient in volume resuscitation during ICU stay. And this was based on some hemodynamics. So let's take a look at this. There was a statistical significant difference on CVP differences. You can see in the albumin group, you have a mean difference of 2. There's indeed a difference in MAP. In the albumin group, there's a mean difference of 3.5. And then lastly, there's a change in cardiac index as well. Albumin is significantly improved with a cardiac index difference, mean difference of 0.61. And while these hemodynamics are statistically significant, I really question the clinical significance of such small mean differences. The second reference paper within the surviving sepsis rationale is the Albios trial. This paper explored the difference between 20% albumin and crystalloid administration in patients with severe sepsis and septic shock. However, this paper did it unlike any person listening to this lecture right now. They administered albumin for a goal albumin level of 3 grams. Other things to point out, this was a non-blinded trial. In addition, this was an Italian-based only trial. So in summary, the paper used a hyperoncotic solution of albumin. They used a laboratory-driven protocol. It was non-blinded, and it was an Italian-based only paper. The primary outcome of the paper was death at any cause at 28 days. There was no difference. In addition, there was no difference in any secondary outcomes, including death of any cause at 90 days. However, when they started to take a look at their detailed numbers, they noticed a higher MAP, higher static filling pressures, and a lower net fluid balance. And this was interesting. When you took a look at the fine details, there was actually no difference in total fluid administration between the crystalloid and albumin arm. The reason there was a lower net fluid balance was because the urine output was greater in the albumin group. Lastly, there was an unplanned post-hoc analysis showing reduced risk of death in septic shock. As pointed out prior, post-hoc analysis are difficult to interpret. Now, I've already showed you some difference in static filling pressures. Let me show you the difference in the mean arterial pressures in this paper. As you can see, the only statistical significant differences in mean arterial pressures were after 6 hours and at day 1. Now let's take a closer look at the differences in the mean arterial pressures. Now these are the average mean arterial pressures. You have 79 versus 77 and 81 versus 80. Again, statistically significant, but are these clinically significant numbers to be concerned with? So why such the unimpressive results from albumin? Let's try to answer that in the next couple slides. Doing so, let's explore the classic Starling model. This model is what gives us the rationale to administer albumin to our patients in the ICU. Interesting to point out, This model stemmed from experimental models back in 1896, nearly 130 years ago, where the isolated hind limb of a dog was injected with either serum or saline. And while this model is complex, it revolves around the capillaries and especially the postcapillary venules functioning as a semi-permeable membrane. It also states that the transvascular fluid exchange depends on the balance between the hydrostatic and oncotic pressure gradients. You can think of transvascular fluid exchange as the movement back and forth between the intervascular space and the interstitial space. If I could focus your attention to your monitor here. The blue arrow represents the hydrostatic pressure, the red arrow represents the oncotic pressure. As we follow this black line, we're going to move through the postarterial capillary segment, into the capillary, into the postcapillary venule. Within the postarterial capillary segment, you can see that the hydrostatic pressure is greater than the oncotic pressure. This favors movement of fluid from the intervascular space to the interstitial space. This is referred to as filtration. Then we move into the capillary itself. Hydrostatic pressure equals oncotic pressure, which relates to zero net transvascular fluid exchange. Lastly, as we move into the postcapillary venules, oncotic pressure in the vessel is higher than the hydrostatic pressure, and this equates to fluid moving from the interstitium back into the intervascular space. We refer to this as reabsorption. And again, this model assumes that the postcapillary venules are semi-permeable and responsible for the majority of this reabsorption, while the lymphatics play a very minor role. We then manipulate this presumed understanding at times by administering hyperoncotic 25% albumin. The thought is we significantly increase the intervascular oncotic pressure, and this increases reabsorption, leading to refilling of the intervascular space and reduction of edema. Now let's take a look at the updated or revised Starling model. And this revision took place almost 100 years after it was originally created, so this brings us up into the early 2000s now. And this was made possible by advances in laboratory technology. So the revised Starling model may tell us why we haven't seen this big bang for the buck when it comes to albumin shock literature. I don't pretend to be a physiologist or have the ability to explain this as well as some publications. I'm going to keep it simple, but if you would like to learn more about the revised model, I'd suggest you read the articles that are cited at the bottom of the screen. And due to the complexity, I really like to try to break this down to 5 simple points. The first is the discovery of the glycocalyx layer. This is an endothelial surface layer. It's a web of proteins and carbohydrates, and among its many functions, it inhibits passage of large molecules. 2. Knowing this, instead of the classic Starling model telling us that transvascular fluid exchange is a result of hydrostatic and oncotic pressures across that capillary membrane, the revised model tells us that the fluid exchange is driven by the oncotic forces across the endothelial surface itself. 3. The majority of the vasculature consists of non-fenestrated capillaries. So this thought process of semi-permeable membranes just is not accurate. There's a continuous basement membrane throughout the majority of vasculature seen throughout the body. The exceptions to this would be the kidneys, some of the GI mucosal, some of the lymph nodes as well. 4. There's no post-capillary venule reabsorption. And with that said, we come to number 5. Most of the interstitial space fluid is returned via the lymphatic system. In this graphic, you can see that the classic model had us thinking that we had this porous, permeable surface that the fluid and molecules just transferred back and forth, secondary to the hydrostatic and oncotic pressures. But in the revised model, you can see that this just isn't the case. The glycocalyx layer acts like a basement membrane to the endothelium, preventing this presumed degree of permeability. Fluid from the interstitial space enters the vasculature through a small amount of these large pore systems, but the primary route by which fluids return to the circulation is really through the lymphatic system. And if the glycocalyx is injured from anywhere from fluid overload to infection/sepsis, the ability to maintain fluid in the vascular space may be affected. Wow, that is a lot of content, so let's do a recap on this. Transcapillary flow rate is much lower than previously expected based on the classic Starling model. There is no venous capillary reabsorption in the majority of the vasculature within the body. Fluids reabsorb via the lymphatics, and the subglycocalyx colloid osmotic pressure replaces the interstitial colloid osmotic pressure as the driver for transvascular fluid movement. And when it comes to administering albumin, instead of this 3-to-1 rule, we're closer to about a 1.4-to-1 rule. But the revised model does tell us that albumin probably stays in the vascular space better than crystalloids, but albumin will not pull fluid back into the vascular space as we once believed. And next, is there a safety issue to be concerned about? Well, there may be. It's not entirely proven yet, but we worry about infusing a colloid into a patient with a beat up glycocalyx may result in the protein accumulating in the interstitial space causing edema, kind of similar to giving a crystalloid. So at the end of the day, when there's equipoise concerning a treatment or maybe even paucity of literature, I try to ask myself some questions. 1, is it safe? Well, it seems to be for the majority of patients, with the exclusion being traumatic brain injury, or maybe you could extrapolate that to the neurological injured patient. 2, is there potential harm? There may be, not completely proven yet, but maybe we could worsen edema if that glycocalyx layer is injured. Is it effective? So in this case, as a volume expander? Well, in comparison to crystalloids, I think the answer is still yes, but not as effective as we once thought it was. And then lastly, is it cost effective? So taking a look at these prices, 5% albumin is relatively expensive when we take a look at the cost of a crystalloid. So with all that information, where do we go from here when it comes to albumin administration in a shock patient? Well, if you ask me, if you choose to use albumin, you really should individualize the use of it based on your patient's condition and disease processes. Now let's move on to crystalloids. Crystalloids are the preferred fluid for resuscitation in the non-bleeding patient. And why? Well, it's because they're inexpensive, they're always available, and honestly, there's no literature saying anything is better. So most of us know when it comes to crystalloids, there's hypotonic, isotonic, and hypertonic. Examples of hypotonic would be dextrose, 0.45% saline, or 0.25% saline. If you've ever been confused with previous readings, when it comes down to D5W, it's isotonic in the bag, but it's hypotonic once it gets into the patient. Examples of isotonic crystalloids would be normal saline, lactated ringer, plasmolite, and normisol. And when it comes to hypertonic crystalloids, we're talking 3 to about 7.5% saline. We use isotonic crystalloid for volume resuscitation, and then the discussion and literature review for hypertonic saline for resuscitation is outside the contents of this lecture. Focusing in on our isotonic crystalloids, first we have chloride-rich solutions, and this would really be normal saline, 0.9% saline. Then moving on, we have IV fluids that start balancing, they start buffering, and this would really be our lactated ringer. And then lastly, we have a true buffered and a true balanced IV fluid, and this would be mainly plasmolite, and in some regions of the country, there's also normisol. Let's first look at normal saline, or as some folks joke around, abnormal saline. This is 0.9% saline. So in this and subsequent slides, I'm going to compare plasma and IV fluid contents. So if you're not familiar with this information, I urge you to pause the lecture and take the time to explore the differences and similarities. Not to digress, let's dig into abnormal saline. So 1. 0.9% saline has a high sodium content in comparison to the plasma level. So 154 milliequivalents per liter in comparison to 140 in plasma. That's a lot of sodium. In fact, that's 9,000 milligrams of sodium. That's 52 snack bag sizes of Fritos. Next, and most concerning to me, 0.9% saline has a very high chloride content, so 154 milliequivalents per liter in comparison to about a mean chloride level of 100 in plasma. Chloride and bicarbonate are anions, i.e. negatively charged. The body always tries to maintain pH neutrality, so in the presence of a high chloride serum concentration, the kidneys will excrete bicarbonate, and this will cause a non-anion gap metabolic acidosis. Next, 0.9% saline is an acidotic formulation, so the pH right out of the bag is 5.7. And while I don't want to turn this into an acid-base lecture, the strong anion difference is 0 compared to 40 of human plasma. So ion difference is the difference between the strong cations and strong anions. To make things simple, 0 is less than 40. There is a magic break level of about 24. So either way, 0.9% saline is less than 40. It's less than 24. So this is an acidotic formulation. And the last thing to talk about is the osmolality. So this is somewhat difficult to talk about in IV fluids because there's an in vivo and in vitro osmolality. 0.9% saline has an in vitro osmolality of 308. Just a reminder, in vitro is outside the body. The in vivo osmolality is 287. Again, as a reminder, in vivo is inside the body. And for you chemistry heads out there that want to understand why, this is due to the osmotic coefficient of 0.926. Now let's move on to lactated ringer. So first, lactated ringer has a lower sodium content than plasma. This is very important to point out. 129 milliequivalents per liter in lactated ringer. Next, lactated ringer has a reduced chloride content in comparison to saline. Still not perfect, but definitely improved. Lactated ringer is an acidotic formulation as well, but not as bad as 0.9% saline. You can see that the pH is 6.4. The strong anion difference is lower than plasma. However, it doesn't break that threshold of 24. So yes, an acidotic formulation, but not as bad as 0.9% saline. Next is the osmolality is lower than plasma. And again, this is a very important concept to take a peek at, especially when taking care of specific patient populations. The in vitro osmolality is 273 and the in vivo osmolality is 254. And here you see lactate is used as a bicarbonate equivalent. We call this a buffering agent. So lactate is converted to bicarbonate and it's buffered by the liver. And please take note that lactated ringer has 4 milliequivalents per liter of potassium in it, and we'll come back to that in some future slides. And one last thing to add about lactated ringer. There's some antiquated concerns that lactated ringer can cause lactic acidosis. This generally is not true. The lactate in lactated ringer is sodium lactate. You're worried about lactic acid. So in the absence of full-blown acute fulminant liver failure, you're usually safe to not have to worry about this concern. Now let's move on to plasma-lyte. So first, plasma-lyte is balanced. So balanced to that of plasma. As you can see in comparison, sodium of 140, chloride around 100, magnesium around 2, and potassium around 5. Plasma-lyte, in comparison to 0.9% saline and lactated ringer, is actually an alkalotic solution. Again, you can see that the plasma has a strong anion difference of 40, where plasma-lyte has a strong anion difference of 50. That's higher than plasma. That makes it alkalotic. The pH in the bag is about 7.4. I also want to point out, when it comes to potassium, there's 5 milliequivalents per liter in a bag of plasma-lyte. Let's now take a look at the osmolality of plasma-lyte. So it's 294 in vitro in the bag, but in vivo it's around 271. So this is a tad bit shy lower than what the plasma osmolality is. This is important when we're taking care of specific patient populations. Another neat fact about plasma-lyte is there's no calcium in it. So it prevents a lot of IV incompatibilities, and in fact, it's actually compatible with blood transfusions. And then lastly, gluconate and acetate are used as bicarbonate equivalents, better known as buffers. Let's explore that a little bit closer. Gluconate, lactate, and acetate are what we refer to as bicarbonate precursors, or bicarbonate equivalents. So some astute folks listening to this presentation might say, well, wait a minute, why can't we just make a balanced bicarbonate infusion? And well, technically you could. However, it would be a pharmacist's nightmare, and on top of that, you cannot store bicarbonate infusions. So in place of that, we have bicarbonate precursors or bicarbonate equivalents. So long story short, whether it's gluconate, lactate, or acetate, it makes itself down to the citric acid cycle, where it produces water and CO2. And those familiar with the bicarbonate buffer system understand that this will essentially form into a bicarbonate. When we look specifically at plasma-lyte, we're looking at gluconate and acetate as bicarbonate precursors. So gluconate is probably the least effective between lactate, gluconate, and acetate because 80% of it is cleared out by the kidneys, leaving only about 20% of it to be metabolized by the liver. And in fact, we do need a good functioning liver to metabolize gluconate. Acetate, on the other hand, is a very effective buffer, and one of the best things about acetate is it doesn't rely solely on the liver to metabolize, nor is acetate metabolism impaired by severe shock. So now let's briefly compare normal saline versus balanced solutions. So first, it's important to state the historic concerns of normal saline, and that is hyperchloremia, increased non-anion gap metabolic acidosis, maybe an increase in AKI, an increase in renal replacement therapy, and maybe even an increase in mortality. But what does the most up-to-date literature tell us? So first, we have the SPLIT trial. And the SPLIT trial showed obviously more hyperchloremia. It was actually interesting how they pointed out in their paper. They surveyed the study clinicians, and they had them guess based on laboratory data whether the patient was on the saline arm or the balanced arm. And 2/3 of the clinicians guessed that the patient were on the saline arm, indicating a higher rate of hyperchloremia. However, this paper showed no difference in AKI, no difference in renal replacement therapy, and no difference in mortality. The criticism of this paper, 57% of the patients were elective surgery patients, mostly being CT surgery patients. Only 4% of the patient population were actually in shock. Next, we have the SMART trial. And this showed a lower risk of major acute kidney events. It did show more non-anion gap metabolic acidosis though. And in a pre-specified sepsis subgroup, there was a lower composite outcome, and this included death, renal replacement therapy, and persistent renal dysfunction. Then there was the BASIC trial, and this showed no difference in mortality or rates of renal replacement therapy. And while in a sepsis subgroup, there was a signal towards reduction in mortality, the confidence interval crossed 1, which probably makes no difference between the two groups. Then there was the PLUS trial. And in this trial, they showed no difference in mortality or renal replacement therapy. So this is a lot of literature and somewhat conflicting, so there was a meta-analysis done. And the meta-analysis was very difficult to interpret, but maybe there was a reduction in mortality, and if you believe that, the reduction in mortality would be more so in sepsis. At the end of the day, what crystalloid do I pick? Well, I picked the one that causes less hyperchloremia, less non-anion gap metabolic acidosis, the one that's cost effective, and it would be great if I could see a mortality benefit in one of the crystalloids that I use, but that's questionable. Well, a balanced solution, more so Plasma-Lyte, gives me at least 3 out of the 4 of these criteria. And at the end of the day, someday that we do find a mortality reduction, that would be great too. Now let's take a look at some specific patient populations in regard to crystalloid administration. First, let's take a peek at the neurologically injured patient. I once again want to point out that in human plasma, sodium is 140 and osmolality is 280. Comparing these 3 IV fluids, 0.9% saline, lactated ringer, and Plasma-Lyte, saline looks to be the best choice here with a sodium level that's higher than the serum plasma of the body at 154 milliequivalents per liter, and the osmolality is anywhere between 287 to 308 depending if it's in vitro or in vivo. The least ideal crystalloid and probably the most injurious is lactated ringer. As you can see, the sodium level is low at 129 and the osmolality is much lower than that of the human plasma. So let's eliminate lactated ringer. So next is Plasma-Lyte. This is something that I've wondered for a very long time because the sodium is 140, which is that of the human plasma. However, when we take a look at the osmolality, especially the in vivo osmolality of 271, it has the potential of being lower than human plasma serum. So can Plasma-Lyte be used safely in the neurological injured patient? And most folks say no. Taking a look at the previous meta-analysis that was discussed, we can see an increased risk ratio of using a balanced solution in traumatic brain injured patients of 1.26. Most would extrapolate this to any neurologically injured patient. We most likely should refrain from using Plasma-Lyte in the neurologically injured patient unless there's an advisement by a neurocritical care intensivist. Why such a big concern with using a hypotonic hypoosmolar crystalloid in a neurological injured patient? Well, as you can see here in the graphic, comparing the intercellular fluid compartment and the extracellular fluid compartment, including the intervascular fluid compartment. If we introduce a large amount of water to the intervascular space and the interstitial space, water will follow the concentration gradient, increasing the water content of the cell and causing it to expand. This could be catastrophic in a neurological injured patient, which is probably already suffering cerebral edema and increased intracranial pressures. According to the Monroe-Kelly doctrine, there's a limited space in the cranial vault, and this increase in cerebral edema could worsen patient outcomes. Now let's take a peek at the DKA patient. Is the literature telling us what IV fluid, what crystalloid to use? So if you take a look at the American guidelines and even the updated British guidelines, the mainstay recommendation is normal saline. However, even in the UK updated guidelines, there is mention of balanced crystalloid administration. So what does the literature tell us? Plasma-Lyte demonstrates no harm in a DKA patient. There may be a trend towards increased insulin sensitivity, and this is probably because there's a trend towards faster DKA resolution, i.e. faster acidosis resolution. There seems to be a shorter insulin infusion median time, and there's definitely less hyperchloremia. So balanced solutions is safe and probably effective in the DKA patient. If you use the single bag approach to treating DKA, logistically lactated ringer seems to be the easier choice. However, if you use the 2-bag treatment method in DKA, that's 1 bag as a resuscitative fluid and 1 bag as the dextrose fluid, you could easily use Plasma-Lyte in this situation. Now let's take a look at the renal patient or the patient with hyperchloremia, or both, the patient that's prone to hyperchloremia. Looking at numbers alone, there's 0 milliequivalents of potassium in normal saline, 4 milliequivalents in lactated ringer, and 5 milliequivalents per liter in Plasma-Lyte. Looking at these numbers, there's an unfounded fear and dogmatic teaching that giving a balance or a buffer solution will increase your potassium level. This simply is not true. And why is this not true? So first, potassium's volume of distribution is larger than the extracellular compartment. So by definition, the volume of distribution is a parameter representing the propensity of a drug, in this case an electrolyte, to remain in the plasma or to redistribute to other tissue compartments. So if you have a high volume of distribution, this drug or electrolyte leaves the plasma and enters the extracellular space. If you have a low volume distribution, this remains in the plasma. So potassium has a high volume of distribution. So the potassium equilibrates between the intercellular and extracellular compartments. So giving this 4 to 5 milliequivalents per liter is not an additive effect. It does not increase your potassium level. Then some folks might just say, well, just give normal saline to be safe. However, in large volumes, normal saline causes a non-anti-GAP metabolic acidosis, which indirectly increases your extracellular potassium level due to the acidosis. So is there literature backing what I'm saying here? And the answer is yes. And it's actually 3 trials in renal transplant patients, the patients that I would be most worried about being hyperkalemic or having the risks of forming hyperkalemia. Both these papers studied either normal saline or lactated ringer. So remember, lactated ringer has around 4 milliequivalents of potassium per liter. And take a look at some of the results here. 19% of normal saline patients developed hyperkalemia in one of the papers that was defined by a potassium level greater than 6. This was compared to none in the LR arm. Normal saline patients had a higher rate of non-anti-GAP metabolic acidosis, which we're cognizant of, and 31% of the normal saline patients were treated for acidosis, where none in the LR arm required that intervention. In another paper, there was a mean change in serum potassium of about plus 5 milliequivalents in the saline group, and there was actually a small reduction of the potassium level in the lactated ringer group. And then the last paper showed a mean potassium increase of 0.37 milliequivalents per liter in the normal saline group, and there was no significant change in the lactated ringer group. This would be an example of literature versus dogmatic teaching. I'd like to finish up this presentation by briefly reviewing some fluid administration principles. The first one is the Rose model, which highlights the 4 phases of fluid therapy. So we have resuscitation, optimization, stabilization, and evacuation. Rose. And while there's a massive amount of information to discuss while covering the Rose model, I just want to hit the highlights. Resuscitation. This is understanding that volume has the main goal to improve the stroke volume. We do this with IV fluid boluses followed by fluid responsiveness assessment. Then we move on to the optimization. We're focused on maintenance. So this is volume according to the patient's individual needs. Again, fluid responsive testing and assessment with bolus IV fluids. Then we move into the stabilization phase, and we aim towards a net even balance, and we tend to water and electrolyte needs if need be, and I'd really prefer that to be done enterally if possible. And then lastly, we focus on evacuation. This is removing fluid, whether passively or we have to actively diurese, or in some patient populations, we have to use renal replacement therapy. We're looking for a net negative daily goal down to their dry weight. So really the Rose model is telling us or asking us when to start IV fluid, when to stop IV fluid, when to start removing fluid, and lastly, when to stop removing fluid. My personal opinion is many folks focus on resuscitation, maybe a little optimization, and then stabilization and evacuation seem to be an afterthought. And what I'm saying is actually supported in literature. So we have to focus on stabilization and evacuation, or as you'll see in the next slide, de-escalation of volume and fluid therapy. The next principle is the 4 Ds of fluid stewardship. And if you look at this is identical to antibiotic stewardship. We really need to highlight that fluids are a drug and that we need to demonstrate appropriate stewardship. So if we take a look at this, we have drug, dosing, duration, and de-escalation. What we do with antibiotics every day. What I'm asking, what the 4D method is asking, is that you apply the same concepts to fluid management. So during this presentation, we focus mostly on what drug, i.e. fluid, to give. In our subsequent fluid responsiveness and fluid tolerance sessions, we'll discuss dosing, duration, and de-escalation in more detail. So let's wrap this presentation up. We highlighted that fluids are drugs and need to be treated accordingly. We also discussed while fluids can help restore tissue perfusion, they certainly can cause harm as well. We also highlighted the importance of appropriate fluid type selection, and we briefly discussed fluid administration principles. I appreciate your attention to this lecture. I hope you found benefit from watching. Be sure not to miss future volume presentations on fluid responsiveness and fluid tolerance. If you have any questions or feedback, be sure to email me at the email address on your screen. And as always, thank you for viewing.